Coming to question number 29, which statement is true regarding coronary angiography in the presence of proximal thoracic aortic dissection? When we talk about aortic dissection, you have to understand Stanford classification. So you have Stanford A and you have Stanford B. The same classification is going to be applicable for your aortic intramural hematoma as well, as I told you already. Stanford A means ascending aorta is going to be involved. And Stanford B means ascending aorta is not involved. That's all. Remember, more than 70% of the times, your aortic dissection is going to happen in the ascending aorta only, as I told you already. So predominantly are going to deal with Stanford A. And you have to always go for medical therapy for any aortic dissection involving IV beta blockers. That's for sure. And if they ask you drug of choice is esmolol, but in India it's not available, so that's why we go for labetalol more often than not. Or you can go for IV metoprolol also, but labetalol is the standard drug. And in the setting of aortic dissection, the target systolic blood pressure is going to be less than 120 and the target heart rate is going to be less than 60. And that's the reason why we go for IV beta blockers. They are very beneficial. And apart from that, for Stanford A, you have to additionally perform surgery. Stanford B, generally we don't go for surgery unless and until the patient is having some relevant end organ damage. Otherwise, you don't do any intervention. For Stanford A, definitely you need to go for surgery. This patient is having a proximal thoracic aortic dissection, which means we are dealing with an ascending aortic dissection of Stanford A. And one problem with this ascending aortic dissection is the fact that it can extend proximally and it can occlude the coronary vessels. And I told you the right side of the aorta, right postlateral aorta, is the common site for intimal tear. And the dissection can extend proximally and very commonly it tends to occlude the right coronary artery, resulting in inferior MI. Or it can even occlude the left coronary artery, causing anterior MI. But inferior MI is common. Or sometimes the dissection can extend even more proximally and can cause leakage of blood into the pericardial space, resulting in tamponade. Remember, most of the times, aortic dissection is going to come with hypertension as hypertensive emergency. But if you see a patient with aortic dissection and hypotension, think about tamponade. That's possible because the proximal portion of the aorta is covered by pericardium. And sometimes the dissection can extend proximally, involving the aortic valves, resulting in acute aortic regurgitation and acute severe heart failure also. And that is the reason why they're asking whether coronary angiography has to be performed or not before going for surgery. Because there is a danger that your right or left coronary artery could be occluded by the dissection flap. But it's very clear in the IRAD study where routine coronary angiograms before doing surgery for type A dissections is not going to be of any benefit. It's not going to impact mortality. So option D is wrong. And option A is also wrong because it's not recommended prior to surgery. It's only going to waste time. So go for surgery. That's more important. Maybe you can assess the coronary vessels during the operation itself by doing probably an intra-op T or probably intracardiac echo you can do. So you can assess the coronaries at that time. So no need to do a separate coronary angiography. It's going to only kill time. And it was performed in 45% of the IRAD patients with acute type A dissection is wrong. I think it's performed only in approximately around 10% of patients who are enrolled in the IRAD study. The dissection flap may have traveled down the coronary arteries, perfectly correct, and that can result in occlusion of one of the coronaries, which can result in STEMI. And of course, the right answer for this question is going to be option B.